All right, at this time I would like to introduce you to today's speaker, Steve Hyde. Steve is a principal consultant with Stroudwater Associates, where he is a leader in population health practice. Steve has over 30 years experience in healthcare. He has held CEO and or board positions and has experience in various areas such as hospitals, disease management, physician practice management, managed care health plans, and preferred provider organizations. He advises hospitals and medical groups on how to survive and thrive in the new healthcare environment. Steve earned his BA in Finance from Michigan State University and his MBA from Harvard Business School. Steve is a popular speaker and author of 2 books. Welcome, Steve. We're thrilled to have you on as a guest speaker.
Thank you, Kim. I really appreciate the opportunity to be here. Can you hear me?
I can hear you, Steve. Yep. And if
okay, great. Thanks. Want to make sure. Well, thanks everybody for being here. Over the next hour, I want to talk about issues specific to engaging rural hospitals and rural providers in population health. There's some particular problems there that are unique to rural environments, and I hope to clarify some of that. And then suggest 7 key activities that and principles to get you through that those issues. Let's see. I don't yet have technical issues here. Kim, I'm not getting a response.
Okay, I'll
there we
your
go.
slide.
Okay. Can you give me the control?
Yeah, I'm working on that. You should be able to advance your slides now with the arrows at the bottom of your screen.
Okay, let's try that. Okay, here we go. Sorry.
All right, great.
So here's what I want to talk about over the next hour, including Q&A. First, just very briefly talk about where volume-driven fee-for-service has brought us, where it's heading. It's not good. Ask the rather, to me, rhetorical question, is there a solution? I think there is. It comes in terms of population health, but I want to talk about one particular major barrier to population health, then talk about how to get over that barrier to cross what we call the shaky bridge from volume-based fee-for-service to value-based population health. Then hope to have a few minutes for Q&A at the end. And I believe people can enter questions on the chat box as well as we go along, although I'll hold off answering those until the end. First, I want to start with a personal experience. I live in Colorado. I'm presenting now from my office in Colorado Springs. I'm an avid skier, and about, I don't know, 7 or 8 years ago, I was skiing Monarch Mountain in Colorado, and went through some particularly challenging kind of wet powder. I fell rather hard, hurt my knee, and 4 or 5 days later, went to see my friendly local orthopedist who just checked out my knee, felt it, asked me a few questions, and pronounced that I was in luck, that I had pulled my medial collateral ligament, my MCL, and he said, that one will heal. He said to ice it, take some ibuprofen, and gave me a series of exercises that once I felt like it. He said in 4 or 5 months I should be completely back to normal. Then he handed me a slip of paper, and I looked at it, and it was an order for an MRI on my knee. So I immediately asked, I said, well, how much does this MRI cost? And he said, well, it's $1,500, but you've got insurance. I said, well, actually, I have high deductible insurance, so I have to pay the $1,500. And I loved his response. You know what he said? Oh, then you don't need it. To me, that kind of encapsulates a bunch of the problems that have arisen from the fee-for-service system. I even asked him afterwards. I said, well, then why did you order it? And he said, oh, I just wanted to study in your file in case you ever come back. And by the way, 6 or 7 years later, I've not gone back. So I want to summarize where the dominant fee-for-service volume-based system has brought us. First, 30 to 40% of everything healthcare providers do adds no patient value, or may even subtract patient value. It's wasted. Half of all medical care is substandard. It kind of goes with the first one. Your chances of walking into a random doctor or hospital in this country and getting the generally accepted standard of care, I'm not talking about the latest New England Journal advances, but the generally accepted standard of care, it's a coin flip. If you're an adult, it's about 55%, child, 45%. If you have atrial fibrillation, you're out of luck. You got about a 25% chance of getting the standard of care. If you have breast cancer, you're arguably lucky in that at least you've got about an 85% chance of getting the standard of care. 75% of everything we spend goes to treat preventable disease, and unfortunately very little of it is preventable by doctors because the vast majority of it relates to 24/7 personal lifestyles around eating, smoking, alcohol, and behaviors that directly affect 3 blood sugar measures, blood pressure, blood sugar, and cholesterol. All individually controllable to a great extent for most people, but it requires 24/7 lifestyle changes, relatively little of which can be controlled by a physician who you may see 2 or 3 hours out of a year at most. This is always a shocking number. Transaction costs, the cost of billing and collection, are estimated to consume between 20 and 31% of every healthcare dollar. Those compare those to the transaction costs for everything else we buy on a daily basis: food, clothes, housing, transportation, recreation. It's 2 or 3%. It's the cost of a credit or debit card transaction. So healthcare transaction costs are an order of magnitude higher. They don't need to be, they shouldn't be, and there are ways to fix that. Finally, shouldn't be a surprise to any of you, hospitals are facing growing reimbursement pressure from all payers, including their patients. Medicare, just what's wired into the law right now is projected by CMS that Medicare rates will fall below Medicaid's by the end of this decade. Although you'll see here they're actually predicting or including the assumption that Medicaid rates will stay flat, which we all know is not happening. In fact, if anything, it's a race to the bottom between Medicare and Medicaid. It would be one thing if Medicare were to just tell us, okay, guys, we're going to cut your fee-for-service rates by 2% a year or 3% a year for the next umpteen years. They don't do it that way. They do it by way of narrow, targeted programs, most of which involve hundreds of pages of regulations and special situations that claw away money. So in some cases give you the opportunity to be paid more money, but at the end of the day, it is not a comprehensive approach. It's kind of catch as catch can, and it's what I call death by 1,000 cuts. So the issue is, will critical access hospitals, which cost reimbursement, will they be exempt from Medicare cost cuts? And I would say when pigs fly. Medicaid, I've already talked about. Just Google the term Medicaid state cuts, and you can fill 15 slides with these kinds of headlines about the pressure that the states are under and what it's doing to their budgets and how they're responding. Commercial insurance pressure is the really scary part, because commercial insurance is where providers have historically done the cost shift. said, okay, we're going to lose money on Medicaid. We may break even on Medicare, although increasingly losing money on that. But at least we can charge the commercial carriers $1,700 a year average more per family of four for the services we provide them than we do for the government programs. That is going away very rapidly, and that's really scary. First, under the Affordable Care Act, there is a lot more regulatory scrutiny of premiums. Commercial insurers are cramming it down with fewer hospital rate increases. In fact, we're seeing more decreases, especially for insurance exchange participation. The commercial payers generally have a reduced ability to accept cost shift. So the old game of making your bottom line on commercial and losing it on the government is that you need to be thinking of an end game there. Shrinking market share. Commercial insurance is shrinking as an overall percentage of the market. Government is picking up more and more of it. And finally, the payers, the commercial carriers, are as desperate for solutions as you are. They clearly perceive that their business models, their traditional business models, are endangered, and they're looking for solutions. Employers, self-funded employers, same story. Their costs have gone up at such a rate that they're mad as hell and not going to take it anymore. And they're beginning to engage in a lot of activities to get control of those costs. Patients have become an increasing factor. Since the managed care revolution in the 70s and 80s, patients were pretty much exempt from caring about how much anything costs because, for the most part, they were paying co-payments, modest co-payments for any service they might receive. Over the last 10 years, the growth of high deductibles and co-payments largely going away has meant that patients are more and more exposed to not just the cost of care, but the price of care. And since most provider payment systems, billing systems, are set up to be run through the insurance company first while collecting a co-payment at the time of service, on a deductible, you never know how much that patient is going to owe you until the claim is adjudicated. And that's often 30, 60 days later, when patients have a remarkable tendency to forget how important that visit was at the time and to pay for it. And this line extends through 2013. It does not include the significant increase in high deductible plans through the insurance exchanges, which is the predominant type of coverage that people are buying now. So the big question, I've already tipped off that to me it's rhetorical, is there a solution to these problems? I think there is, and it's under what we now call population health, a new business model that produces patient value, that focuses on patient value, that emphasizes it and rewards it. And patient value, if you Google the term value, you'll find it's quality divided by cost. In other words, the higher the quality of any good or service and the lower the cost, the higher the resulting value. So what is population health? There are a lot of different definitions out there. A lot of them are just not very helpful, in my opinion. Here's the one I like. Population health is any provider arrangement with a payer in which you, the provider, agree to provide a defined set of care to a defined group of payer members. That's your population. It's not your community at large. It is a contracted group of member patients where you must accomplish three things. First, you've got to improve the group's medical outcomes through primary care patient coordination. Second, you've got to reduce their per capita costs. And third, and critically, you've got to contractually make sure you're capturing the savings, or at least the lion's share of the savings, from the value you've just created. Because when you reduce the group's per capita costs, most of that is going to come out of your top line because you're reducing it through utilization of the services that have traditionally been your profit drivers. So the good news and bad news about improved value, the good news is that if you manage it right, measure it right, higher quality actually generates lower per capita patient costs. But if you stay on fee-for-service, it'll kill you because, again, you're cutting your own throats from the top-line revenue and being paid less and less. So while you may be improving outcomes, saving a ton of money, all the savings accrue to the payers, not to you, and that's not a sustainable situation. Let me give you an example. 2 out of 3 won't make the cut. 10 or 15 years ago, Duke University Hospital set up a very, very innovative for its time congestive heart failure disease management program. CHF is the largest, most expensive chronic disease. People with advanced CHF are known for revolving door into hospital ERs and inpatient beds on a regular basis. So Duke put in place a disease management program, very innovative. They reached out to the patients to actively and proactively help them change their diets, weigh them every day, make sure they made their regular doctor appointments and attended them, resolved any transportation issues, make sure they got their prescriptions and that they actually took them. And as you can see, they cut total cost of CHF by $8,600 a patient, or 40%. Unfortunately, because they were still on a fee-for-service basis, almost that entire amount of savings came out of Duke's revenue because it cut hospital utilization, it cuts all the revenue that they had been generating from these revolving door people. And they were losing a massive amount of money on this in addition to paying for the disease management program. So finally, they very quietly discontinued the program. But 3 out of 3 does work. And here's a counterexample. Geisinger, it's a health plan and a provider in Pennsylvania. They embedded case managers with their primary care physician practices for 33,000 of their enrolled members to facilitate improved quality and coordination of care. The results, we got an 18% decrease in admissions, 20% in readmissions, lowered cost by 7.1%, for total estimated savings are over $16 million. And if you look at how many primary care physicians it would take to coordinate the care for 33,000 patients, it's somewhere between 14 and 20 doctors. So you can see the potential impact of a primary care physician under a population health model in being able to generate significant savings and profit. But this worked because for Geisinger, they're also the health plan, and they were able to keep the savings. So the question arises, what is the potential? How much savings can be achieved? And as I suggested in my earlier slide, it's massive. CHF, again, is the largest. This graph shows the costs of defective care as a percentage of total costs. And you see CHF is just out of control. But also the usual suspects, COPD, diabetes, on down the line. And if you look at the bottom bar, overall about 45% of care, which fits with what I was saying earlier, is effectively defective. Meaning if you were to apply, for example, for CHF, the kinds of innovations that Duke did, you would significantly reduce the cost of care. And there are a lot of examples of programs out there that have accomplished just that. So there's a lot of money to be saved. The target is huge. What I have here is it's our population health framework. It's an implementation framework. It's a little complex, but it shows over time the phases of what an organization needs to do to move from volume-based fee-for-service to value-based population health. The top part of this triangle relates to how you modify your care delivery to focus on primary care physician coordination of care. The bottom part relates to changing your revenue model so that as you generate improved outcomes and lower cost from the activities on the top part of this chart, you're being rewarded for it by the changes you're making in your reimbursement models on the bottom part. And the center part is how you integrate those, the integrative function that brings those two together and makes sure that both are happening simultaneously. I talked about, though, the major barrier to population health, and here it is. Population health requires large populations. You need, in general, in this, excuse me, a rough rule of thumb, a community needs at least, in my opinion, about 100,000 people before you can seriously look at in having the actuarial confidence necessary to predict utilization and cost so that you can engage in risk-based provider reimbursement. But also, if you're in a market of 10 or 15,000 people in a rural area, you're just not going to get a lot of attention from the payers when you try to go talk to them about doing something innovative. It's just not big enough to justify them making the extra efforts. So individual rural hospitals have small populations, which is the primary reason why historically HMOs, managed care, ACOs, all population health innovations have been almost exclusively urban. And you might think, well, there are a couple of exceptions, Geisinger, which is significantly rural model, and also Intermountain Health in Utah, but those both started from an urban base and then expanded from there. So they started with large aggregated population. So the solution, we believe, is if one rural hospital doesn't have the market, cooperate with multiple rural hospitals. So if one 10,000 population hospital can't do it, put together 20 of them, get 200,000 in population, operating cooperatively to change how they practice and to negotiate with payers for population health. So I'm going to talk about how to do that. And it comes under the rubric of crossing the shaky bridge to population health, from volume-driven fee-for-service to value-driven population health. So I'm going to talk about 7 principles for getting there. And the first is organizing. Organize for population health. How do you get a bunch of rural and critical access hospitals to organize to do this? The step we recommend is to establish something called a community care organization. It's a narrow rural provider network focused on patient value. It serves to aggregate multiple rural and critical access hospital populations for that critical mass for actuarial confidence and to attract payers. You'll restrict this network only to the payers that are willing to commit to population health and reimbursement, not for fee-for-service. You want to contract with payers that are willing to do it on your terms, as well as their own, reasonable ones. It's not for existing fee-for-service or cost contracts. For payers that aren't willing to engage in population health, say, fine, you can continue to access this, but only through the PPOs that we belong to, for as long as we choose to belong to. The CCO then actively secures and manages risk-reward-based payer contracts. So representing this aggregate of multiple hospitals, the CCO is the central organizing mechanism that goes out, talks to payers, engages them, and negotiates with them for value-based contracts. Simultaneously, the CCO provides support to the individual hospitals and medical groups to move toward primary care physician-focused quality and care coordination across this network. I'll talk a little bit more about that in a second. It's a legal entity with corporate powers, would be owned or controlled by the member hospitals themselves. I would have a governance structure, certainly, setting strategy, policy, and accountability. The idea here is it allows the local hospital to retain its independence as an individual locally owned and run hospital, but with contractual accountability to a CCO. So this was created as an alternative to rural hospitals becoming acquired, having to resort to being acquired by larger regional urban hospitals. It allows them to retain independence. There are CCOs currently either developing or in operation in 3 states, Illinois, Colorado, and California. It looks like Washington State is about to join. Principle 2 is implementing primary care patient care coordination. This, of course, is the current system where patients are kind of on their own in figuring out who they need to see and how they're going to enter the system and move around in it. Where under patient-centered medical homes, primary care, the patient continues to look at their primary care physician as their care provider of first resort, but they're additionally agreeing and looking to that primary care physician as the coordinator of all that patient's care throughout the medical system. And to do it right requires building over time a team of providers, nurse practitioners, coaches, care coordinators that provide that function of coordinating the patient care throughout the system. Third principle, negotiating with payers. 4 major principles there. First, you need the payer to engage in what we call voluntary positive patient attribution to your PCPs. In other words, you want the payers to provide incentives or requirements to their members to choose one of your participating primary care physicians as their care coordinator, and they agree to that function. Second, I don't know of any way to manage population health without getting claims data. There are a lot of people busting their pick trying to figure out how to integrate multiple EMR platforms. Someday we'll get there, and it will be the millennium. We don't have that now. Claims data is extremely valuable. It's something that most payers hold dear. They don't like to share it. You got to get it. And we're finding that the payers that are really tuned into population health understand this and are willing to share that kind of essential data. Of course, you need to set up reimbursement mechanisms that reward you for producing value. I'll talk about that a little bit more in a second. And here is the key. You need to develop a collaborative relationship with the payer. No longer the head knocking or our way or the highway, but you're actually getting together and talking cooperatively about a common goal, improving patient outcomes, lowering costs, and increasing both of your respective market shares and profitability, survivability, sustainability. And what we're finding in talking to payers on behalf of hospitals and CCOs is if you've got the population numbers and a credible model, the payers will talk. You don't have to demonstrate right out of the box that you got a world-class patient coordination capability, but you have to show that you're moving in that direction. And there are a number of steps you can take that are actually very low cost around care coordination that can actually generate a lot of value. Number 4, CCO then, you're prioritizing your markets and you're taking the initiative. You're not waiting for the payers to come to you. You go to them and propose approaches. I used to be in the managed care business. I was CEO of an 8-state managed care company. And all the time we were in that business, I had exactly one provider, one hospital, come to us with a really innovative idea, which we grabbed hold of, adopted, and tremendously benefited both organizations. Once you get organized, take the initiative. So in looking at markets, a great place to start, especially if you have your own self-funded health plan or partially self-funded, start with your own employees. you control the benefits, you have influence over the population, and there are a lot of things you can do to engage in population health, learn how to do it, and get on a rapid learning curve with your own employees and dependents. Plus, when you do that, it gives you a lot more credibility in the marketplace when you're going out and saying, we can do this. Private health insurers, excellent place to start alongside your own employees. All of the big ones and most of the medium-sized ones are tuned into population health. They haven't figured it out. And surprisingly, a number of them don't know any more about it than you do. But they all realize it's something they have to engage in productively. Medicare Advantage, where you can also go to the private payers that are engaged in Medicare Advantage, can be highly advantageous and as an alternative to setting up your own accountable care organization. Although one of the three CCOs that I mentioned is actually has actually set up its own Medicare Shared Savings Program. Medicaid managed care in the states that have it, which are most of them now, can be a very good organization to approach. And self-funded employers, if you've got large self-funded employers, which typically for rural areas are school district, city, county, sometimes you'll have a large private employer, it can be advantageous, but I will tell you it's a very difficult market to penetrate for a whole bunch of reasons. Insurance exchanges are starting to look interesting after they have established their viability, which still remains to be seen in a number of states. That could be an attractive opportunity as well. But the point is, with the CCO, with the aggregation of population, you can begin to behave like a large system in an urban area. Principle number 5, value-based payment implementation. The ultimate goal, quite frankly, is to get as close to global capitation as you can, for reasons I'll show you in a second. But basically, that's how you get rewarded for value, because if you're getting essentially 85 or 90% of the insurance premium, then any savings you generate from population health, you get to keep. That said, please do not go away from this saying Steve Hyde says we've got to go to full capitation. You don't do it right away. Generally, you start small. You can contract with payers. Often they'll provide care management fees for your engaging in primary care physician population health coordination. They may provide enhancements to payment based on your quality metrics, and allows you to get moving on the learning curve to do population health, to change how you're practicing medicine, and to get rewarded for it. However, this should never be your end game, because under those modes, the more successful you become, the more you're giving the savings to the insurance company and potentially punishing yourself. So it's very important that you move up the scale, moving to shared savings, where you establish a capitation target, and if you beat it, you get a percentage of the savings, to a shared risk reward, where you're saying, well, we're willing to go at some risk now, some downside risk, but we want a greater share of the savings. And ultimately, we've got this thing nailed, we've got a good population, we know what we're doing, and we have the actuarial confidence to go with full capitation on a global basis. And you can actually do that with surprisingly small numbers if you buy reinsurance or have the insurer provide reinsurance for you to cover the costs of those outlier, hideously expensive cases that come up from time to time. So what is the value of capitation? Let me show you what this can mean in an ultimate model. And again, this is a primary care-based approach. Primary care and population health becomes the center of the universe. It becomes the central profit center of the care delivery system. It moves away from the hospital to primary care. That's a very difficult concept for a lot of hospitals to get their brains wrapped around. It's no longer about maximizing admissions, lengths of stay, OR utilization, ER imaging, and all of that. It's about maximizing the effectiveness of population health that's generated by the primary care physician, where all of those facility-based services become cost centers that you want to minimize by improving outcomes and reducing demand. But if you set it up right, you're rewarded for doing that. As I said, it's a very difficult strategic concept for CEOs and a lot of especially CFOs to get their brains wrapped around, but it's absolutely critical. Organizations have done that, Kaiser being the exemplar of that, have been extremely successful. So here's the model. The average patient seen by a primary care physician in this country has somebody spending almost $8,700 a year on, whether that's Medicare, Medicaid, private insurance, the patients pay themselves. And the average primary care physician has a patient panel size, active patients, of about 2,300. Well, research on patient-centered medical home, team-based care coordination suggests a reduced patient panel size, and ranging from about 1,400 up to something over 1,900 patients. So a fairly significant reduction because you're providing more intensive care and care management to those populations. But if you look at it in terms of capitation, if essentially under that patient-centered medical home model, each primary care physician's patient panel has somebody spending $12 million a year on them. Now, the typical primary care physician may be only billing $400,000 or so of that and taking home an average of $180,000. But under patient-centered medical home, you need to think of this as that doctor controls a total spend of $12 million, because under population health, all those patients have agreed that that doctor is becoming the care coordinator, and that team is managing that approach for them. So if you think in terms of that primary care physician generating revenue of $12 million under a full global capitation, the ultimate approach, then you go back and say, well, if that doctor can successfully cut the cost of care by 5%, which isn't a lot given the potential out there, they just generated a bottom line of $600,000. And there are a lot of examples of patient-centered medical homes in the second year cutting the cost of care in the neighborhood of 10%, which is $1.2 million. That becomes the profit center that drives this. This is what the CCO ultimately is attempting to achieve. And this is what the urban systems are as well. Primary care physician becomes your profit center. The sixth principle is operational efficiency. This is actually very basic. I could have mentioned this one number first. It's a baseline requirement. You've got to do that. You're crossing a bridge. You're not going instantaneously to population health. Most rural hospitals can do a lot to improve their revenue cycle, to optimize that, to improve their collections, their coding, their billings. Cost accounting, know what your real costs are. Engage in waste reduction, lean, Six Sigma, whatever quality improvement and process improvement activities are out there. These are immensely valuable, whether you're a fee-for-service or a population health program, continuous quality improvement on down. Seventh and finally is adopt a rapid learning curve. Get on this thing. You don't have to be world-class right out of the box, but you do have to beat your personal best from year to year. And where you get most rewarded for that is starting with your own employees, because you're paying most of the freight on the premiums anyway. And if you can reduce the cost of care and save on premiums there, that's a total win. Private insurers. increasingly very willing to engage in this. So where you just have to beat your personal best. You don't have to be a world beater. Rapidly move up your learning curve. Learn what works, learn what doesn't. Appropriate good ideas from other successful programs. Healthcare is very collaborative, and there are tons and tons of demonstrations of projects, of things people are doing out there, and they tend to be very open and willing to share what they know. Take advantage of that. Ask for help. If we could just call them Rolodex. Have a contact list of people you can call to ask, how do you do this? We tried this, it didn't work. I read about in a journal that you guys are doing something really innovative there. What do we do? Don't be shy about that. You don't have to reinvent it. There's nothing here that you need to do that hasn't been done somewhere by somebody before. And you need to be able to access that. And the nice thing about having the central CCO organization is you can have people who are totally dedicated to that while you're dedicated to running your hospital and helping move it toward the improved care coordination approach. So I'll conclude by saying, so one of my favorite quotes, Medal of Freedom winner John Gardner, what we have before us are some breathtaking opportunities disguised as insoluble problems. And with that, I'll move to questions. To unmute, I think you do *2. My chat box doesn't show any questions on it, Kim. Not quite sure how I access those. But bring it on. Any questions? Don't be shy. I'm a nice guy.
Press *2 to unmute your line.
Great audience. Everybody understood everything I said, and agreed with it, disagreed with it.
I have a question.
Is there someone on the line? Have a question or a comment?
I have a question.
Thank you.
One of my questions is for really small critical access hospitals, and we're talking like $10 million, where do you suggest they start going? Because having limited population is part of a problem, but how do you suggest, I mean, everybody's working on operational efficiencies, but getting involved with a CCO or some aspect, how do you see that happening? And I guess that's the real unclear part.
What state are you in?
Montana.
Montana, okay. I believe isn't there an organization of rural and critical access hospitals in Montana that's doing some stuff on some innovative stuff on population health? Or do you belong to a rural or critical access hospital network in Montana?
Yeah. Well, and I know that there's a group which we're involved with that is starting to look at this, but there's no formal CCO that I know of.
Right. In our experience, the best place to start is with the associations. That's in Illinois, Colorado, California, where they have them, and in Washington State. That's exactly where they started. That you have existing aggregations of these hospitals that exist for other reasons, but where the organizations themselves have credibility, they have staff, and have the ability to kind of get the ball rolling with a feasibility study, for example, where they introduce the concept of CCOs to their members, invite them to participate in a feasibility study that's very low cost, that you assess the market. If you get 5, 10, 20, some cases 30 hospitals saying, hey, we're interested in this, then you go in, you do a demographic analysis, you say, what is the primary service area population size for each one of these, all of them? Who are the major payers? what are the rates, what's going on in that market. And then if you see that there is that critical population size and credible payer, then you start actually putting the thing together. And you go out and start talking to payers and said, we've got 20 hospitals in a rural area that account for 200, 300, 400,000 people that it's the land that population health forgot. And this is a very significant market opportunity for you. And it's an opportunity for you, the payer, to do something really innovative. And I will tell you, the payers in the other states, Blue Cross Blue Shield of Illinois has jumped all over this. Payers in Colorado and California, very, very interested in this. Because, again, they realize that population health is a model they have to move to. So the place to start is to, at least in every case I've seen so far, is with whatever association or aggregation group you're involved in now, and they can then take the lead. And in each of the three cases, it was those associations that actually went through all the mechanics to start the CCO and to help it hire staff and become operational in very close cooperation with each other. So it's kind of a continuation of existing roles held by these associations. It seems to be working pretty well. Does that help?
That helps a little bit. I guess one question that I just, in a presentation just heard of now, is that there's like a national CAW association, or CCO, that's kind of developing. And do you see that being more feasible than a state-by-state CCO?
That, yeah, the National Rural ACO Coalition, or RACO or something, yeah, that's a private company. They're very aggressively moving into Medicare shared savings in a number of states. I don't know how many people they have. It is an alternate model. It's a different model. I encourage you to look at that. The CEO of that, her name is Lynn Barr. She's very sharp and very actively recruiting hospitals to engage in that. That's an alternate model. What we like about the CCO approach is that it's potentially an all-payer approach. It isn't just focused on Medicare shared savings. Medicare shared savings has a number of issues yet to be worked out, and the success of the initial Medicare ACOs under Pioneer and shared savings has been pretty limited. And nobody seems to know just yet, for the ones that are succeeding, exactly why that is and how that can be replicated. I think ACOs have a lot of potential, but they can be fairly expensive and fairly risky to engage in. But I encourage you to certainly look at that as well. That is another option.
All right, thank you.
Good. Anybody else? Any other questions? That was a great one.
Yes, I have a question. I hear you say that CAWs are going this way, but there are some key members of healthcare leadership as well as government that say that cost-based reimbursement will not be going away. Given that we're very unsure of which way we will be going, what are some focus areas and specific actions you would take?
That's a great question. Nobody knows what's going to happen to cost-based reimbursement. We know there's a lot of pressure on it politically to justify it. There's a lot of great counter-arguments coming back about the essential nature of rural hospitals, rural critical access hospitals. So I cannot predict how that's going to go. But the fact is that cost-based reimbursement is only for the government programs. You still got, in most cases, a significant private payer base in your communities. Those pressures are not going to change. If you believe, if you're doing well now, and you believe that fundamentally nothing's going to change, that population health is a flash in the pan. It's just another one of those things that comes and goes, and you'll be able to continue with the model you have into the future. There's no reason to even mess with this. Just keep doing what you're doing. The problem is I don't know anybody who believes that. And looking at your options is really important. And again, nobody jumps into these CCOs, commits a lot of money to it without checking it out, kicking the tires, and seeing if it has a decent new car smell to it. And it's not expensive to get started, to look into it, especially if you work it through the association. So I would suggest to you that regardless of how you feel the political winds are going to blow with respect to cost reimbursement, it's a very, very good idea to figure out some options in your state association or whatever association you've got. Should be open to that. That again, that's that's pretty basic. But those 7 activities I outlined, I think are pretty good ways to engage in looking at your alternatives. Any other questions? Was that helpful, by the way?
Yes, it was. Thank you.
Okay, thank you.
Steve, could you please outline the process to obtain claims data from CMS, Medicare, state Medicaid, and privates across multiple hospitals in a network?
Yeah, if you're going to get claims data for Medicare, there are 2 ways to get it. The detailed line-by-line claims data. One is to participate in Medicare Shared Savings, ACO. The other is to participate in Medicare Advantage, where you would contract as a contracting provider with one or more existing Medicare Advantage plans. I don't know of any way to get those claims otherwise, although CMS is just recently announced that they are going to be releasing the Part B claims on an annual basis nationwide, although it will be totally blinded where you cannot identify the patients, which greatly limits the usefulness there. Medicaid depends on the state. If you're participating in a Medicare or a Medicaid managed care, you get the claims. If not, it can be very difficult. The most difficult claims to get are private insurance companies. Even if you're engaging in contracts with them, some make it very difficult. They think it's proprietary information, the amount they pay, the contracts with the other hospitals, and it varies greatly state by state. Illinois, we find working with Blue Cross Blue Shield there, they seem very open to sharing claims data. They see the reason for it, the need for it, how helpful it is for the providers. Blue Cross Blue Shield, Blue Cross of Michigan, no way. They said, not proprietary information, it's ours. We'll give you reports that tell you what we think you need to know. I think, though, the shift is moving toward realization that claims have to be shared. You can't run, in my opinion, I've run population health, managed care organizations, HMOs, and consulted with them and worked with them for decades, and there is no way to effectively do it without good claims data. And so essentially it's something you negotiate unless you happen to be participating in the Medicare programs. Any others? Tim, any other chat room questions I need to
I don't see any
address
right now.
Okay, good.
Well, thank you, Steve, for presenting a great webinar.
Well, thank you. I'll point out we've got 2 more coming up. I think I had a slide on that, which I lost here. But we're doing one coming up on saving community hospitals by saving primary care, which greatly elaborates on some of the things I talked about today. It's really how to turn primary care into your success profit center through patient coordination in population health. I think that's when, on the 11th of February, Kim?
Yeah, and on the screen, the left-hand screen, we have upcoming help webinars as well as upcoming
there you go.
PMG calls. Mm-hmm.
Great, and that will be on February 11th. I'll be sharing the presentation dues with my colleague Terry Bauer, and then on the 25th, this one is I strongly encourage you to tune into. I'm going to be doing it with my colleague Bill Patton, who's just recently retired from Blue Cross Blue Shield of Illinois. And they have one of the most innovative care coordination programs I've seen. It's low cost, it's low tech, it's highly effective, and can be a great transitional model for moving toward patient-centered medical home without having to engage in all the organizational complexity and the costs required to do level 1, 2, 3 NCQA. So I strongly encourage everyone to be on that one and both of them. With that, Kim, I'm very grateful for the opportunity to chat with people. I hope it's been helpful, and I look forward to continuing to work with you folks on the subsequent webinars.
Thank you, Steve. To register for any of our upcoming webinars or PMG calls, please follow the link on the screen, and that it will take you right to the registration page. Following Steve's Population Health Series, we'll be holding a Performance Management Group call on February 27th titled, What Do I Need to Do Now to Prepare for Value-Based Models and Population Health Strategies for the Future? Please take the short online evaluation for this webinar, and the link is right on the screen. If you would like to receive 1 hour of